So when symptoms are consistent with hypoglycemia, what you do, you just quickly do a capillary blood glucose. If less than 70, treat as high if less than 70, and if you cannot treat, get the glucose levels. So आपके पास पेशेंट आया है, वो शेकी है, वो स्वेटी है, वो डायबिटिक है, वो शेकी है, स्वेटी है, उसको ऐसे सिम्टम्स हो रहे हैं, इरिटेबल हो रहा है, और आपके पास ग्लूकोमीटर नहीं है घर में, आप देख रहे हो, आपको लगता है कि पेशेंट, सो आपने क्या करना है, आपने उसको ट्रीट कर देना है। अगर आप ग्लूकोमीटर नहीं है और आप उसका शुगर मेजर नहीं कर सकते हो, ब्लड ग्लूकोज मेजर नहीं कर सकते हो, आपने उसको ट्रीट कर लेना है। ठीक है, ऐसे ही ट्रीट कर लेना है जैसे 70 से कम है उसके लेवल्स। सो अगर पेशेंट कॉन्शियस है तो 15 का रूल आपने याद रखना है, 15 ग्राम्स ऑफ ग्लूकोज और इक्विवेलेंट आपने देनी है, और ब्लड कैपिलरी ग्लूकोज आफ्टर एवरी 15 मिनट्स आपने चेक करना है। अगर ग्लूकोज लेवल इज लेस देन 70, repeat glucose intake and measure glucose again at 15 minutes. If it is above 70, so then give a large meal, a high slowly absorbed carbohydrate supplement. So tell him अगर उसने खाना खाना था या उसका डिनर का टाइम था या जो भी, आप उसको खाना दे दो. So that will prevent repeat hypoglycemia. It will release the sugar slowly, gradually, and prevent the repeat hypoglycemia. If the patient is unconscious, you have to administer glucagon. Now it has to be given subcutaneously or intramuscular. If glucagon is not available, which is usually not, because it's not available in a lot of setups as well, in big setups, hospital setups as well. So what you do is, we can give dextrose water, IV fluid, in the form of IV fluid, dextrose water 5%, and then 25% is given continuous infusion. And once the patient is conscious, then you can give slow absorbed carbohydrate. Here, but if you are not in the hospital and if you do not have IV fluid at home, what you can do is you can put the honey, or you can put jam in the mouth, in the buccal mucosa, so it gets absorbed from there, it quickly gets absorbed from there. So treatment of hypoglycemia, take quickly absorbed carbohydrates such as half a glass of juice, a little carton or small bottle of fruit juice, 5 to 7 jelly beans or sweets, 3 teaspoons of honey or sugar, glucose that contains 15 grams of carbohydrate. ठीक है, so 3 teaspoons of sugar or honey in water you can dissolve and can give it. Follow up with more slowly absorbed carbohydrates such as a sandwich, a biscuit, a glass of milk, a piece of fruit. Retest blood glucose after every 15 minutes. So आप 15 मिनट के बाद you give this, you check the sugar after 15 minutes. Then if it is not rising, you give this again and you check the sugar after 15 minutes until the sugar levels are more than 70. When the sugar levels are more than 70, then you give a slowly absorbed carbohydrate to these patients. So that's about hypoglycemia. Coming to the next acute complication, diabetic ketoacidosis. I've put up this cute picture for you guys to remember. Diabetic ketoacidosis occurs within 4 to 10 hours. It's an acute complications. Patient in history will tell you history of a type 1 diabetic who has missed his insulin dose. Sometimes diabetic ketoacidosis is the very first presentation of type 1 diabetics. So they will not be giving you history of insulin, not taking insulin, but they will be giving history of GI upset and febrile illness, and they will be young patients. So severe abdominal pain and fever, vomiting, nausea. These are the patients, and young girls or boys like 13, 14 years old, and they're coming, and when you will check their sugars will be very high, and that means that this patient has presented, this type 1 diabetic patient has presented for the first time to us with ketoacidosis. So the type 1 diabetics can have first presentation of just diabetic ketoacidosis, no other thing. Maybe saying Yes, maybe they will be giving you vague history of polyuria or polydipsia, and that's why they will be landing. The first time they are landing to the hospital, first time they are being diagnosed, will be because of diabetic ketoacidosis. Breath smells like juicy fruit gum, or this is called cosmal respiration. Sorry, this is the ketonics. Sorry. Breath smells like juicy fruit gum. That is called the ketotic smell, and there will be cosmal respiration. Patient will be thirsty, dehydrated, tachycardia, hypotension, and acidosis will be there. When you will do blood tests, you will see a high blood sugar which is more than 240. There will be hyperkalemia and there will be polyuria. And what is the treatment? You will hydrate the patient, you will give insulin, and you will treat the electrolyte imbalance, high E, and patient will improve. And believe me, these patients are uh, can recover completely. And it has been said that if a patient of DKA expires, that unit should be closed because DKA is a reversible disease. Okay? So HHS is hyperglycemic hyperosmolar state. So this one is usually occurring in type 2 diabetics in older age people. Okay, HHS usually happens in them. Okay, because of infections and different precipitating factors. DKA occurs only when there is insulin deficiency. So that's why ketoacidosis takes place, because insulin deficiency will result in utilization of the of the lipids, and this will result in production of free fatty acids. While HHS occurs because insulin, there is not complete deficiency of insulin, so ketoacidosis doesn't take place, but hyperosmolarity occurs in here. So what's the difference between the two? In DKA, there will be cosmal respiration, there will be nausea and vomiting, abdominal pain, fatigue, patient will be thirsty, sweet, smelly breath, acetone because of the presence of the acetic acid, the acetone, the acidic smell, ketotic smell we call it. Patient can be confused, drowsy, hypotensive, and tachycardic. In HHS, usually presents with dehydration, stupor, and coma. Patient can be unconscious, or it can be lost of alteration, and there can be polyuria for several weeks. There is profound dehydration, hypotension, and tachycardia will be there. Causes of DKA and HHS is stressful precipitating events that results in increased catecholamines, cortisol, and glucagon. So any infection, especially the pneumonias and UTIs, alcohol and other drugs, stroke, myocardial infarction, pancreatitis, trauma, medications, steroid and thiazide diuretics, and non-compliance with insulin. This basically leads to DKA. Even in patients, DKA is more common is seen in type 1 diabetics. HHS is commonly seen in type 2 diabetics. But type 2 diabetics at the end stage, when they are requiring insulin, they will not be presenting, they don't usually present with HHS, they start presenting with DKA. So it's not rule of thumb that if there is DKA, patient is type 1 diabetic. It can be that patient has burned out pancreas, and now in type 2 diabetic patient has burnt his pancreas out, completely finished the pancreas, and now has no insulin, so he is presenting with DKA. So diagnostic criteria for DKA and HHS, we divide DKA into three categories: mild, moderate, and severe. In mild, the plasma glucose will be more than 250 with pH between 7.25 to 7.3, bicarbs between 15 to 18. Urinary ketones will be positive, serum ketones will also be positive, and effective serum osmolality is variable. A9 gap is present more than 10. Alteration in sensorium or mental obtundation is not there, patient is alert. In moderate, the sugars are more than 250, pH is coming down, it is between 7 to 7.24, bicarb is much lower, 10 to 15, serum ketones are positive, urinary and serum ketones are positive, A9 gap is more than 12, and patient is alert or drowsy. In severe, the glucose level more than 250 with pH of less than 7 and bicarb of less than 10 with ketones positive, and A9 gap is more than 12. So DKA, we can see important things here is there's diabetes, the sugars are raised, there are ketones, we can see the ketones are positive, K is for ketoacidosis, so ketones, they are positive, and A is for acidosis, so you see the arterial pH which is showing acidosis in these patients. In HHS, this is hyperglycemic hyperosmolar state, as the name says, so the glucose levels are more than 600. pH is more than 7.3, that is, it is normal. Bicarbs are normal. Ketones may or may not, they are not usually raised. They are low. The ketones are low in urine and serum. And as I said, it is hyperglycemic hyperosmolar, so the osmolality over here will be more than 320. That is how you calculate osmolality. So osmolality you calculate by using this formula, 2 into Meyer sodium plus glucose. This will give you osmolality. And to look for the A9 gap, you use this formula, sodium minus both the negative ions, you add them, and then the sodium, you take the sodium and you subtract them. So sodium minus chloride plus bicarb minus sodium is the formula for the A9 gap. Okay, very busy slide. This is how you treat the DKA. So management of DKA is to correct the acidosis, to get rid of the ketones, and to bring down the sugar levels. So we do the ABCD. We maintain the airway, the breathing, the circulation, and we look at the diabetes. How will we treat the diabetes? We'll treat the diabetes by giving insulin. Electrolytes and pH, we have to follow the electrolytes and pH. We'll treat that. Fluid replacement as patients are dehydrated. Hourly glucose monitoring has to be done. HbA1c has to be done. Fixed rate insulin is used in these patients. Clinical judgment on clinical grounds, patient has to be judged whether how much fluid and how much treatment has to be given. Hourly ketones are needed, and you need to refer these patients to the diabetic tree. So all three of the following should be present for the diagnosis of DKA. The blood glucose level more than 11 or 200 capillary ketones raised, and venous pH less than 7.3. Excuse me, with a bicarb of less than 15. So this within 1 hour, 0 to 60 minutes, you have to restore the circulating volume. So you give a bolus of 500 ml of 0.9% sodium chloride, and you give, once systolic pressure is more than 90, you give 1 liter of the 0.9%. So if the pressures are low, then you give the 500 ml bolus and bring the pressure up. And if the pressure is more than 90 systolic, then you give 1 liter over 1 hour. Along with this, you do insulin therapy. You start fixed rate insulin infusion at rate of 0.1 ml per kg per hour, and continue patients long acting, or if the patient is on long acting insulin like Lantus, Largine, you continue that. Okay? Or you just, or if the patient is not, then you can start, just give the regular insulin. You have to do hourly capillary glucose, ketones, bicarbs, potassium at 60 minutes, 2 hours, and 2 hours thereafter. So ग्लूकोज और कीटोन्स आवरली आप कर रहे हैं, और बाय कार्ब और पोटेशियम को पहले 1 घंटे पे करना है, फिर 2 घंटे पे करना है, फिर 2 घंटे पे करते रहना है, फिर 4 आवरली करना है। उसके बाद जब स्टेबल होने लग जाएंगे तो 4 आवरली हम करेंगे। 60 मिनट्स से 6 आवर्स के बीच में यू रीअसेस द पेशेंट एंड कंटिन्यू मॉनिटरिंग द ब्लड कीटोन्स एंड ग्लूकोज, venous gas for pH, bicarb and potassium at end of each fluid bag. So आप fluids देते चले जाएंगे और आप उसके साथ pH और potassium करते रहेंगे। Continue fluid management आपने करनी है। 1 liter आपने पहले 1 hour में दिया, then you have to give another liter in 2 hours, then 1 liter over 2 hours, then 1 liter over 4 hours. So आपने अगले 6 hours में 3, 4, 5, 6, 7, 8 hours में आपने 3 लीटर्स देने हैं, ठीक है। सो टोटल 9 आवर्स हो गए पेशेंट को एडमिट हुए हुए, आपने ये देने हैं। और आपने जो है पेशेंट को असेस करना है, कीटोन्स देखना है कि वो फॉल कर रहे हैं, बाइकार्बोनेट्स राइज कर रहे हैं कि नहीं। कीटोन्स शुड फॉल, not fall at should not if ketones and you change the rate of infusion if the ketones are not falling at the rate of 0.5 millimoles per hour, and bicarb is not rising by 3 millimoles per hour, and glucose is not falling by 3 millimoles per hour. 6 to 12 hours हो गए पेशेंट को आपके पास आए हुए, आपने रीअसेस करना है। अब आपने if glucose is less than 14 or 215, ठीक है, if seek senior medical advice if not responding. If glucose is less than 250, 14 millimoles or 250, then you start with the 10% glucose at 125 ml per hour alongside sodium chloride. So आपने जहाँ पे आप सोडियम नॉर्मल सलाइन का आप दे रहे हैं, सोडियम क्लोराइड दे रहे हैं पेशेंट को, उसके साथ साथ you have to start the dextrose water 10% glucose. Continue fluid management, 1 liter of sodium chloride over 4 hours and then 1 liter over 6 hours, and you reassess at 12 hours. Metabolic profile need to be done. Ketones and glucose hourly, and pH and potassium, venous gases and potassium bicarbonate at each fluid bag. 12 to 24 hours पे DKA should have resolved by now. So within 24 hours, DKA should resolve, and reassess and monitor vital signs. Review metabolic parameters at 12 hours. Check venous pH, bicarb, potassium, as well as ketones and glucose. Check if DKA has resolved. If not, seek senior advice. When you will say कि resolution हो गई है, resolution is defined as ketones less than 0.6 and venous pH over 7.3. If DKA has resolved, what you will do is you convert the patient to subcutaneous insulin if patient is eating and drinking well, and switch to variable rate IV insulin infusion if patient is unwell or unable to eat. So आपको उसको पहले फिक्स पे रखा था, फिक्स से आपको वेरिएबल पे डालना पड़ जाएगा, यानी कि आप उसकी शुगर्स के हिसाब से you will adjust the dose of the insulin. And if patient is eating and drinking, then you can convert the patient on the subcutaneous insulin. Potassium supplements is very important. It should be according to blood glucose. So with the potassium levels, we see potassium being measured everywhere. So it should be according to blood potassium levels. If the potassium levels are more than 5.5, no replacement is done. But if it is between 3.5 to 5.5, then 40 millimole per liter of infusion fluid is given. And if less than 3.5, then you have to ask from the senior, because you will need to go through the main CVP, the big veins you need to give the fluid, give the potassium from. So what happens to potassium? You might have hyperkalemia initially before starting the fluid, but when you start giving the therapy, you start insulin, the potassium starts falling, because the dehydration gets corrected, and then the insulin also causes shift of potassium into the vessels, intracellular. So there is intracellular shift of the potassium, so patients start having hyperkalemia. So this potassium has to be corrected very carefully, and it has to be monitored and calculated very given to the patient very carefully, Again, a very busy slide. So this is a slide in which we are again looking at the same thing. So I'm going to go through step by step, going through it. So complete initial evaluation, check capillary glucose and serum or urine ketones to confirm hyperglycemia and ketonemia and ketonuria. Obtain blood for metabolic profile. Start IV fluid, 1 liter of 0.9% sodium chloride per hour. So you give IV fluid, you determine the hydration state. Severe hypovolemia, give 1 liter of sodium chloride. Mild dehydration, evaluate corrected sodium. Serum sodium high or normal, then give 0.45% sodium chloride. If it is low, then 0.9%. Okay. When serum glucose reaches 200 for DKA or 300 for HHS, change to 5% dextrose with 0.45% sodium chloride. So these are different. Actually, the treatment protocol for DKA and HHS is little different between the UK protocol and American protocol. So this was NHS, the UK protocol, the University of Birmingham. It has come from University of Birmingham, and this is the American protocol. So there is a difference between the two. The major difference is the bicarbonate difference. So here you can see they have not replaced the bicarb because this, according to them, to the UK, when we will correct the acidosis with the insulin and fluid, the bicarbonate doesn't need to be treated, and it will come up. But the Americans, they say that if pH is more than 6.9, you don't need to give bicarb. But if it is less than 6.9, then you can give bicarb to these patients along with the potassium chloride over 2 hours, and repeat every 2 hours until the pH is more than 7. So there is a controversy, and we don't know what the UK people, from UK, what is coming from UK is that by giving bicarb, there are chances of putting patients into cerebral edema and causing pulmonary edema to these patients, while Americans, they think that it is okay. So it depends on how much the pH is, how sick the patient is. You can balance the condition, you can look at the patient and decide accordingly. So these are, but I'm telling you because some people will be saying to you that you have to give bicarb, and some people will be saying no, you shouldn't be giving bicarb. So you should know that both ways of the treatment are correct ways of the treatment. It is just the idea, or there is the this just an argument, or there is what can I say, इख्तलाफ है दो group thought processes के बीच में about the bicarbonate. But you need to know that you can also give it, and why it is not preferred by the UK people is that it can cause cerebral edema, it can cause pulmonary edema. So they say that by giving just insulin and fluids, if you can correct the acidosis, will get corrected by itself when you correct these things. So IV regular insulin you give by IV route. In DKA, you give either by rate of 0.1 unit per kg body weight as IV bolus. You give it as IV bolus, and then you give it as infusion. In HHS, you give it as bolus and IV infusion. You don't give initially in HHS. You don't give the infusion. You give fluids, and you look at the osmolality. If osmolality is not coming down and sugars are not settling, then you start insulin in those patients. If serum glucose does not fall by at least 10% in first hour, give 0.14 units per kg as IV bolus, and then continue the previous treatment. So you can keep on giving them bolus. You can keep on giving them bolus, or you can increase the dose of the infusion you are giving these patients. In DKA, when serum glucose reaches 200, and in HHS when it reaches 300, reduce the infusion rate to 0.0 to 0.05 units per kg per hour, or give rapid acting insulin at 0.1 every 2 hours. So you can give an infusion or subcut insulin in case of DKA. while in here you just reduce the dose of the insulin, and you keep the sugars. In case of DKA, you keep between 150 to 200, and over here you keep between 200 to 300, till in case of decay, until the decay is resolved, or until the mental in HSS, until patient is mentally alert. You keep on checking the electrolytes, and when the sugars are less than 200 in DK or 300 in HHS, you change to 5% dextrose with 0.45 sodium chloride at 150 to 250 ml per hour. We check electrolytes, blood urea nitrogen, venous pH, creatinine, glucose every 2 to 4 hours until patient is stable. After resolution of DK or HHS, when patient is able to eat, we initiate the subcutaneous multi-dose insulin regime. To transfer from IV to subcutaneous, continuous IV infusion, continue the insulin infusion for 1 to 2 hours after subcut insulin begun to ensure adequate plasma insulin levels. We call it um, shoot. Uh, I don't. We overlap, so we are actually overlapping the uh, um, subcutaneous with overlapping the subcutaneous, which we are going to start multi-dose with the continuous IV infusion. This we need to do for 1 to 2 hours so that the patient doesn't go into DKA. Otherwise, patient may go into DKA again or HHS again if it is not done. Potassium establish adequate renal function. Urine output should be more than equivalent to 50 ml per hour. If potassium is less than 3.3, hold insulin and give 20 to 30 milliequivalent per hour until potassium is more than 3.3. If it is 3.3 to 5.2, give 20 to 30 milliequivalent potassium in each liter of IV fluid to keep serum potassium between 4 to 5 milliequivalent. So, the fluid you're giving, you can give 20 to 30 milliequivalent of potassium in that. Then if potassium is more than 5.2, you do not need to give potassium, and you just check the potassium after every 2 hours. So that's the acute complications. Patients, they get better. As you can see, within 24 hours these patients come out of DKA. It is a very hectic time for the for doctors, because you have to check the patient, you have to it's when you get these patients, you will find out next year when inshallah you will be doing house jobs, you will find out that when you get these patients DK, तो फिर आपकी कॉल जो है समझो ख़राब हो गई क्योंकि आपने सिर्फ पेशेंट देखना होता है. And the good thing about DK, if you really work with them, and if you really follow these protocols, these patients within 24 hours are completely out of this complication, this acute complication, and they're completely stable and they can survive. So especially the DKA patients. So very hectic time, just say the slides are busy, the management is also busy like that. When on ground, when you're doing management, you are